All right, everybody's recording. We have attendees joining us now as we speak. Thank you all for joining us for today's webinar presentation entitled Decision Models and Technology in Psychiatry. These webinars from MHDC are provided free of charge to our community, our health data community, and we are very pleased to offer a presentation such as today's from Dr. Daniel Barron at the Brigham and Women's Hospital. We will begin very shortly. We're letting people sign on as we speak, and then we'll get started very soon. All right, welcome everyone. My name is Denny Brennan. I'm the Executive Director of the Massachusetts Health Data Consortium. And I want to welcome you to today's webinar presentation from Dr. Daniel Barron at the Brigham and Women's Hospital entitled Decision Models and Technology in Psychiatry. MHDC's web series comprises about 30 webinars a year. That's what we anticipate completing this year. And they're dedicated to advanced technologies, organizational transformation, social determinants of health and health inequity, the policy and regulatory landscape, and other significant trends and events shaping the health data world as we know it. We are going to today spend with you an hour or more as we do usually, and we encourage you to raise your hands. We can unmute your microphones, but we really want to encourage a conversation today as much as a presentation. You will be able to unmute your microphone, or we will unmute it for you if you raise your hand. We will also be undertaking a poll during today's webinar that will allow you to put your phone up to the screen and scan a QR code or enter a URL and participate in a poll that Dr. Barron has put together. We have also, as you can see on the screen in front of you, listed any social media information that you might have, you might want to have if you're interested in live tweeting or following the tweet from this. If you do want to raise your questions in a quieter manner, please use the Q&A function on the Zoom screen at the bottom of your screen, if that's where it's located. I'm using a Mac, so I don't know if I'm speaking for, I know I'm not speaking for everybody in the audience. And finally, when we exit the webinar, you will have an opportunity to complete a very brief survey. We encourage you to complete the survey. It's very brief. It helps us understand if we're doing good work and how we can do it better. And with that, I'm going to stop with the rules of order and say that it is my great pleasure to introduce Dr. Daniel Barron from the Brigham and Women's Hospital. Daniel, I'll turn it over to you, and thank you for joining us for today's webinar.
My pleasure. Thank you for the invitation. I'm going to share my screen. And here we go. All right, can everyone see that?
We can.
All righty. So I figured I'd start off with a little description of who I am and how I ended up in Massachusetts to be with y'all here. So my background is in brain imaging, and both for my grad school and during med school, I was very involved in MRI analyses, and specifically in epilepsy and in mental health conditions. However, in residency, I began to wonder whether the things that I was looking for in the brain imaging data could be more precisely defined. And so I began to think about digital phenotyping as a way to quantify what I thought was relevant clinically. And then after this, I did a fellowship in pain medicine at the University of Washington, became very interested in functional status, which is the current focus of my research. And so since I've been in Massachusetts, it's been a busy time. We had twins on the 2nd of September last year, and then I was double boarded as of last year, and we're really enjoying living here. My book came out on the rise of big data psychiatry, which is a lot of what I'm going to be presenting today, ideas and topics from that book. And at the Brigham, I am directing this pain intervention and digital research program. And we're structured as a clinical research program where every patient will be a research participant in observational studies where they receive standard of care. Here's my awesome research assistant, Melanie Fu, and 2 of our locations in Weymouth. And overall, we're trying to measure and quantify what we think is clinically relevant with the long-term goal of being able to improve clinical care. And this strategy that we're implementing in what we call the Pain-IDR, the Intervention Digital Research Program, is the core of what my book is about and the core of what I'm going to present to you on today. So after a brief prelude discussing some Massachusetts or Framingham specific analyses and kind of data collection, I want to describe what I view as the clinical problem specifically in psychiatry, how technology and biomarker development can proceed, and then types of decision modeling that I think are promising. So again, as part of the warm-up here, I'm viewing the clinical problem overall, the goal of clinical data is to manage uncertainty, right? And so whenever a clinician meets with the patient, our goal is to figure out what has happened to bring the patient into the clinic and what we're going to do to help the patient in whatever way that they think is important. And so within this interaction, the patient comes to the table with goals. They behave in a specific way. They're telling us things, which is part of behavior. They're showing us things. Maybe they have pain. Maybe they have, poor sleep, depending on mental health conditions. And I am trying to understand what sort of treatment might be helpful for a patient, and then also populate a running diagnosis for that patient. So I'm behaving in a specific way to elicit more information from the patient. And so overall, the goal of this interaction is to manage uncertainty. And so what we do clinically, oops, I don't know how that chromosome got there. So in clinical data can be broken down into 3 broad categories, right? So there are subjective symptoms, which is what the patient describes, which depending on what's going on, they might have any of these type of verbal complaints or verbal statements. They might, depending on their age, they might be like one of my kids right now. They might be just fine, hot and shaky, or okay. And qualitatively, there are observable signs, which are things that I, as the clinician, will observe looking at a patient, right? So you can look at, what their phenotype. Basically, you glance at them and say, oh, this is a child, this is an adolescent, adult, later age adult. Could also perform a physical exam where if they say they're hot and shaky and they feel warm to the touch, you might think that perhaps they have a fever. However, being able to diagnose a fever is a little bit different. There are quantitative observable signs which are responsible for that level of diagnosis. And so there are instruments which we've developed as a, you could say species, as a community, to quantify things that we believe are important. Right. So in this case, if a patient says they're hot and shaky, if they feel warm to the touch, or you have some reason to believe that, you probably want to crystallize that piece of information by measuring a temperature. And of course, there are other types of quantitative observable signs that we can gather. We could test the blood for white blood cell count. An age could be considered a quantitative observable sign, or at least a data point. So I think this framework is very important. This is the way clinicians are taught in medical school. And all of these fall into the category of phenotypes. And so there's a lot of information here, but as we can see, it changes over the lifespan, right? And it can even change moment to moment. Like temperature can change moment to moment. Blood pressure could change, heart rate. And so being able to understand what role these data play in clinical decision, I think, is very important if we're going to be collecting large scale data. And so here's another way to present the same information, right? And so if we have subjective symptoms, We start again with that self-report. We ask the patient what the problem is. They report that they feel hot and shaky, their body hurts, okay? It's important to note that there are dependencies to every type of data, right? And so if you're asking a patient to tell you how they feel, that implies that the patient not only can introspect and understand how they feel, but also that they can articulate the way they feel in a language that you understand, right? And so there are multiple levels of dependencies in that interaction, and that can be limited by the patient's ability to sense or even their cognitive state, which limits their ability to express. Qualitatively, again, those physical exam signs, the things that I would observe as a clinician, those are in large part based on my ability to observe and to gather data, right? So those are significant dependencies that vary clinician to clinician. The limitations in that case would be my senses and my brain, perhaps whether I'm well caffeinated that day or slept well, which doesn't happen as often as I would like these days with those twins around. But all of those are limitations to my ability to, describe and gather specific types of clinical data. And then we have quantitative observable signs. So again, instead of warm to the touch, we would measure temperature, right? So the measurement of temperature has dependencies, or it is dependent on the calibration of the thermometer, of the instrument, which in turn is developed through technology and innovation, right? I mean, there's a long and beautiful history behind the development of the thermometer and its application in clinical practice, which I won't describe here, but it's well worth checking out sometime. There are a few great essays online. And so again, the goal of all this data isn't just an academic exercise. The goal in a clinical interaction is to figure out how to best treat the patient, right? So what treatment are we going to give for someone who feels hot and shaky, is warm to the touch, and has a temperature and white count as described here? That's the goal. So here's another example. So imagine and I would like to get some participant engagement here, if that's possible. I see that we have a few people online. And so we've got a patient with chest pain. It's radiating down their left arm, and it started an hour ago. What are the sorts of things that people would think are relevant to further evaluating this? Like what sort of physical exam signs or what sort of tests might be indicated in this case? Let's see. Instead of questions, I guess we could put answers in the bar here.
Well, I was going to say that, under, the subjective symptoms, there is probably more that the patient could report if they were engaged in some dialogue with a clinician or in an effort to narrow down what might be the subjective symptoms. Is that part of this exercise, Dr. Barron?
Sure, yeah. So you'd ask them to specify, not just when it started, what else is involved, how severe it is, the typical questions you would ask to further evaluate a symptom. And the reason we believe those are important is those have value in a clinical sense because they tell us where to go next. Whoops, got ahead of us.
I was going to say these are concerning symptoms too.
They are concerning, right?
They are very concerning symptoms. You might stop asking questions and start intervening as quickly as possible, or at least making sure that what you're about to intervene with is what's going to help the patient.
I think intervening makes a lot of sense, especially if they roll up to the emergency room. And so what sort of things might an emergency room clinician do to further evaluate this patient? Like tests ordered, or perhaps even—
Can you move your arm? Can you describe the sensation? Or can we take, are you experiencing anything other than chest pain? Are you feeling your heart racing? Is your breathing normal? Questions like that, I guess, would be some of the ones that we might.
Yeah, exactly. So you would ask all those questions. Exactly where I'd be heading. You would observe the patient. You would ask them, how fast their heart is. You would listen to their heart rate, like what you were describing. You would also probably measure it with a blood pressure cuff and a pulse ox. You might get an EKG. You ask them if they have shortness of breath, exactly what you were suggesting as well. You'd get some labs, complete blood count, complete metabolic panel. You would assess for troponins, which is a protein that can exist in your blood, a sign of cardiac distress. You would also get a urine toxicology if you were concerned about that, because there are some drugs that have taken in larger quantities, or sometimes any quantity, can cause chest pain and racing heart. And so all of these data points help us converge on the best treatment plan. Just as you were suggesting, there are some things which can be very concerning, right? You might think, is this patient having a heart attack? Do they have a broken rib, a broken arm? Are they having a panic attack? Any number of things. And so the reason why these data are important, though, has a long history. And I want to describe this before going into where I view psychiatry going, because it's specific to Massachusetts. And also, I think it's directly relevant to a lot of the complexities of psychiatry. And so this is the story of FDR, President of the United States during World War II. And he was known to have occasional headaches, and these progressed over time. And he also had sinus problems, which they thought were infections. You remember, this was in the 40s, so there weren't, amazing CT scans or anything like that where you can look inside the sinus and see if there's an infection. But, he'd been told on and off that these sinus problems were probably just related to a cold. Also at the same time, he was known to have hypertension and maybe heart failure, but it wasn't really clear what that was at the time, because the cardiology was still compared to today, very much in their infancy. And so he was also under an enormous amount of stress, right? I mean, he's the president of the United States in World War II. And so everyone thought that was related. And towards the end of World War II, he met with Churchill, and Lord Moran, who was Churchill's personal physician, took a glance at FDR and said, wow, this guy looks like he's in bad shape. Just based on what I'm seeing here, it looks like he has hardening of the arteries, which was a little bit of wizardry, since no one was really clear what hardening of the arteries meant at the time. And clearly there was no ultrasound to actually look at how hardened the arteries were in the mid-40s. But Lord Moran said that he only gave FDR a few months to live. And they thought that people who believed that FDR was okay and just under a lot of stress were kind of deluding themselves, and that he needed treatment stat. And it's worth noting also that these are just based on subjective symptoms. So FDR said he had headaches and sinus problems, and then qualitative signs, which Lord Moran took a look at him. He's like, this guy doesn't look like he's doing well. At the same time, FDR had been evaluated at the Naval Hospital in Bethesda by one of the leading cardiologists of the time. Same report. He still thought he looked bad. He said they got some labs, so to speak. X-ray had recently been invented. And so they took a chest X-ray, and he had kind of an enlarged heart. His blood pressure is 186 over 108, which it's worth noting was considered relatively normal for the time. Normal tension or normal blood pressure was your age plus 100. And so this was only a few systolic points away from being normal. And he was diagnosed with hypertension, hypertensive heart disease, and cardiac failure, but there was no imminent risk observed. Like, no one thought that FDR was significantly ill. And unfortunately, one of his headaches became very severe while he was sitting for a portrait one day, and he eventually died of a cerebral aneurysm as a result of it was much higher, the hypertension at that time. It was in the 200s. But now we would look back on this and think, oh, the signs were there. The qualitative signs were there if you were the right clinician, and some of the data was there. And so the point is that data just isn't enough. And so here's the clinician that evaluated him, Dr. Brennan, at the Naval Hospital in Bethesda. And here's Lord Moran. And so they had access to similar data. And even, in fact, Brennan had more data. than Lord Moran did, but they reached different conclusions. And so as a result of this, not the specific discordance, but as a result of the United States losing FDR, Congress really rallied around this. So like, this is our war hero, our president, let's figure out what happened here. Like, why did we miss FDR's heart disease? And so they're like, okay, well, let's all study it. And then they had to ask what exactly are they going to study? Because the problem was poorly specified at the time, right? They knew what the outcome of interest that they were after was, which was cerebral aneurysm or heart attack, but it wasn't clear what led up to that. So there were tried and true data points, including physical exam, clinician intuition, and impression. They had these really fascinating ideas like lipids, hardening of the arteries, cholesterol. Those were new ideas for the time, really unproven. Even the electrocardiogram had only recently been invented a couple decades before. And so they weren't sure how valuable that would be. And then there are these latest theories or heroes, there should be another T there, such as lifestyle. Could smoking be involved? Could socioeconomic status be involved in heart disease? So altogether, there were 80 things that they began to study during what later became known as the Framingham Heart Study. And it started in 1947. If you've been reading the news for the last 50 years, you're aware of the great success of the Framingham Heart Study. Things like hypertension, like what exactly is that parameter and why has that parameter changed over time? Things like smoking risk, things like cholesterol levels. These three factors are known to be related to heart disease and a heart attack. And the reason why they were able to find this is they had a crisp endpoint they wanted to follow over time in a large population, and they were collecting a large amount of data in a standardized way for a prolonged period of time. And it's worth noting also that hypertension itself has changed. Like, what is high blood pressure? And so what this indicates is, in the 2000s, hypertension was 130/80. And in 2010, now it's 120/80. And what this indicates is the more data we gather in a standardized way, the better we're able to approximate what it is to be abnormal, right? In the sense of hypertension and not normotensive, right? And so can we parameterize a clinical data point of interest and then trace it longitudinally?
Dr. Barron, just on that slide, a question, what compelled the National Institutes of Health to order the end of the study in 1969? I see that at the top center of your diagram. And then Nixon comes back and says, hold on, we're not going to do that.
It's a great question. I don't know that.
They obviously were finding out great things. Maybe there was, a funding issue or something else, but it strikes me that that study would have been encouraged to continue without interruption for as long as possible.
I think, I don't know the politics of it. So this book right here by Daniel Levy called Change of Heart, Unraveling the Mysteries of Cardiovascular Disease. I would suspect they would describe it there. This figure, I must be covered up. This is from a paper which also has Daniel Levy as a co-author. And they might describe why the NIH ordered its closure. I suspect it's a combination of budget, perhaps an austerity measure, and probably political. All of those things are typically kind of political, but I'm not sure. It's a great question.
Interesting. I'll look it up.
Yeah. Oh, here's the paper. This is the paper where that timeline is from. So yeah, I'd encourage you to go check that out. Yeah, so again, the goal here, obviously my talk is about mental health, but I think in order to understand, what I want to describe about large-scale data collection and data standardization in mental health, I think it's really important to appreciate the success that cardiology has had in defining disease states and in parameterizing what would otherwise be an observable sign, right? A qualitative observable sign. So by transitioning things from, oh, that guy doesn't look so great, into parameters like systolic over diastolic blood pressure that can then be studied and traced over time, we can begin to do really cool statistics. Like we can see where the blood pressures relate to the incidence of coronary heart disease, right? And so that level of analysis isn't possible unless you create large databases longitudinally over time, because it's not obvious, right? So again, the key: longitudinal data collection, standardized data, statistical analyses, pursuing clear endpoints. And then the fourth thing, which I'd interviewed Daniel Levy for my book, and I loved what he said about this. I asked him, I was like, like, gee whiz, it would be really cool to do something like this for mental health care. How did y'all decide on those initial 80 data points, way back when? Like, how did you find the good ones? And he told me very candidly that they were just lucky. They took some of the most promising measures, some of the tried and true, and it turned out that they were really helpful. And so they were very well prepared to execute. And then there was also an element of serendipity. And so I've described an historical context for why large-scale data analysis can be helpful in teasing apart clinical condition that isn't obvious. And so I'd like to describe now, more specific to mental health, what I think the clinical problem is. I'll very briefly go through a series of technologies that I think are promising in terms of being able to standardize what we would otherwise consider an observable sign, a qualitative observable sign. And then I'll describe and try to motivate what I call decision model, what many people call decision models, and how these data can be really flexed in helping us manage clinical uncertainty. So I, as most physicians in the US was trained within the biopsychosocial model. And the goal of the biopsychosocial model is to promote viewing the patient as a complete individual. And one of the seminal papers describing this model is published in 1977 by George Engel, when he said the most essential skills of the physician involve the ability to elicit accurately and analyze correctly the patient's verbal account of their illness experience. Right. So this was at a time when there was a large discussion over the need for more psycho and social approaches to evaluating and treating patients, in addition to the standard biomedical model. And so within this description, the physician is considered kind of an anthropologist who does a brief physical exam, and diagnostic inference requires understanding the context, narrative, and the environment of the patient. So to understand someone, you need to sit with them, hear their story, and kind of enter their world. And I got a kind of a crash course in the limitations of this model when I was a fourth-year med student and traveled to China. It was at the second Shangyao Hospital, where I had the real privilege of working with Dr. Hao Wei, who was at the time, and I believe still is, the director of the WHO's Collaborating Center for Drug Abuse and Health. And so I sat with him in his clinic, and this was an outpatient setting, but within about 3 hours, he saw around 40 patients, which was just a crazy speed. He was a machine. And the issue with all of this was I speak zero Chinese. And so I had no idea what they were saying. And so what did I do? So in the center of the room, there's an orange chair, and Dr. Wei would be sitting in front of the patient, and I was kind of tucked away in the corner. So I just observed very carefully what was going on, right? I gathered qualitative observable signs and jotted them down in my notebook. And there's a wealth of information there, right? So patient walks into the room. What is their expression? Are they walking straight to the chair? How are they dressed? Are their clothes clean? Do they sit? Do they stand, slouch in the chair? What does their voice sound like? Is it high pitched? Are they taking breaths? Do they make eye contact with Dr. Ray? Are they looking at me the entire time? As the clearly foreigner sitting in the corner of the room. I also looked at Dr. Wei. How did he move? How did he sound? Did the patient understand when the conversation was over and get up to leave? And in between patients, Dr. Wei would lean over and ask me to diagnose. And I was surprised that more often than not, I was right. And you could also tell just by observing the patient whether or not the treatment was working. Like, does this guy look sick? Essentially, again, what Lord Moran was doing. And I started to think about how all of this could be measured. And I learned about this school of thought. It's called experimental medicine. It started in the mid 1800s. Dr. Claude Bernard is a French physician. He wrote this beautiful book about an introduction to experimental medicine. And the goal here was to quantify everything possible, right? So measure everything that you can. Instead of rapid pulse, let's get it down to 130 beats per minute, because rapid pulse is underspecified. And this line of thinking eventually led to the design for the randomized double-blind clinical trial. And so this idea of quantifying everything that's going on in the interaction is not without controversy in some cases. There are some people who think that measuring what's happening in a person's life can be dehumanizing on some level, which was a topic of a monk debate that I recently had with Dr. Gerhard Gruner. And I really want to describe this role of technology and measurement as not simply, of being able to develop tools to better measure what we think is clinically important. Like if it's important enough to ask about, it's important enough to measure. And really what it comes down to is, do those data points have value? Like if you think about, who is the better question asker or the historian, you'd probably think Galen if you had to choose between Galen and Anthony Fauci, right? I would imagine Galen was very good at eliciting symptoms from patients or observing, because those were all the tools that Galen had available. Like he didn't have any technologies or instruments. But if you're trying to track down a virus and you're trying to figure out whether someone has a specific virus, and you're trying to develop specific antiviral drugs or antibodies to target a virus, you're going to need some technologies. And in that case, a guy like Fauci would probably be the doctor you'd want to speak with. And so, again, like the goal here is just to add information, right? So instead of just subjective symptoms, qualitative signs, and then we measure. And if those measurements are valuable, then that helps us move to the next treatment plan. And so this is essentially what clinical training is, right? So we're gathering large samples, similar to what you would do in a large scale study, except it's in a person's brain. You're encountering multiple different patients, you're learning from them, you're associating subjective symptoms with specific treatments. And what measurement would do is allow you to formalize that and move it along more quickly. In psychiatry, the problem is more complex because we're dealing with behaviors and types of symptoms that can't readily be quantified in some cases, even though I'd like to argue that there are many that can be. So in psychiatry, if a patient walks into the office, you want to know what their emotional or mental status baseline is, what has changed to bring them into your office, and then how you're going to help them. In order to do that, you must also address specific questions about whether they're a danger to themselves or others. Should you hospitalize them or not? Should you offer medications or not? And that is why we're collecting data. That's what the clinical conversation is about. And it has to be done very quickly, not always as fast as Dr. Wei was. However, the interaction in psychiatry right now is limited to subjective symptoms, which is what the patient reports, and then those qualitative observable signs. And the way we document those is necessarily also limited to, formalizing qualitative signs or subjective symptoms. And so one of the things that I became very interested in residency was, can we just begin measuring and collecting these data? And then so recorded, can we begin to apply technologies to look at what we already believe is clinically relevant? And so here's where I believe technology can be helpful. And this is a field that is more largely known as digital phenotyping, which is using mobile devices to quantify moment by moment, individual level human phenotypes, which again, like in that first figure that I showed you, a phenotype is just a characteristic describing a person. So can we describe things that we think are important and relevant to clinical care using digital devices. And even though typically digital phenotypes apply to things like accelerometer, GPS location, context log data, or what we call passive data, I think that there's a lot of value in considering our online data, which is where a lot of our lives are lived out these days, and then the clinical interaction, which would be video data, and then stress tests, which target a specific facet of behavior. So I'm just checking our chat link here. Okay, we don't have any questions yet.
We
all
have
right,
one
so,
question, though. We did have one question that I wanted to raise. You might be coming up with this or coming to this shortly, but when we think about pain, we think about those pain scores and the faces that range from, you know, a smiling face to a face and an expression of agony. But frequently there's a lot of variability in that data. How do you work with data like that, where the accuracy or the reliability of the responses may be suspect or may change in such a way that it's not explainable?
Great question. I think you're putting your finger on a limitation of pain scores generally. And one of the reasons why pain physicians are beginning to focus on functional status instead of pain scores. For many reasons, right? Two people can both report 7 out of 10 pain, whereas one might have broken their femur and the other has a infected paper cut. So clinically, the treatments for those identical pain scores are very different, right? Even though the level of distress can be the same, right? So a patient with a broken femur can feel as distressed and have as much subjective pain as the person with the paper cut. However, the goal of the clinician is to figure out how they're going to help. And if that amounts to, consoling the patient or helping them develop skills or strategies to reduce that stress, then of course that would be helpful. But, in terms of really figuring out the etiology or the underlying cause of the pain, pain score is less than helpful most of the time. Yeah, of course. And so some of the things that I think can be captured in functional status, like you're suggesting, is kind of what's on our mind. And it's very, how do I phrase this? So what's on our mind is something that's difficult to track down sometimes. However, all of us have devices probably in our pocket, or you might even be listening to this talk on your device where we're on our, almost all people, 81%, this is a few years ago, of adults have smartphones. We spend a lot of time on a computer, and what our interactions with devices leave us with is a timestamp breadcrumb trail for what we've been up to. And this is the same in patients with mental health conditions. You can see this, the last data was from 2015, and these lines have kind of converged now to some extent, depending on diagnosis. And so what we can use this level of data for is really tracing what is on people's mind. And, every second, there are great statistics out how 40,000 people Google something every second. And there are studies out showing that pregnant women are more likely to ask Google something than their MD. There's some really fascinating work that completed suicide in those patients. Search logs are more predictive than their last medical visit. And what that can indicate is that people don't wait until their physician visits to have a crisis. It could be possible that a patient simply, wasn't suicidal at their last physician encounter. However, because Google is, open 24/7, so dependable and fast service, people are more likely to express what's going on to Google. Other things that we can understand from these data are, what is someone's baseline? What were they doing? What were they up to a month or 2 or 6 months ago? Which are questions that aren't obvious. If I were to reflect on what my mood was like last fall compared to today, specifically a given day last fall, or summarize it over last fall, it would be very hard to answer that, especially in patients where they don't realize that something is wrong. And so what I'd like to present here is what I think is a very cool study out of a group at UPenn, where what they were interested in doing was understanding how tweets function. So can they create a distribution for Twitter behavior? And would that behavior correlate with loneliness, which they measured with a questionnaire? And so they discovered two things that I think are interesting. One, well, I guess three things. So one is that there's kind of a circadian rhythm here to tweeting behavior, right? So people go to sleep, they don't tweet as much. And then by around 10 o'clock in the day, people are, having their first level of tweeting. And then maybe they have lunch, they get back to work, and then they go home and then they tweet a lot more. So the percentage of posts changes throughout the day, but across these 6,200 people, you can find clear trends. And also there were clear trends associated with people who were lonely versus people who were not, both in terms of when they were posting, shown here, and also in terms of the types of language they used when they were tweeting. And so in mental health care, what we usually ask people is, to describe what they're doing or the way they're thinking about their life. And, one of the implications of this study, which Guntuku and colleagues described in their paper, is that Twitter data very well could be used to better understand how people are thinking about things based on this study. Being able to predict specific outcomes like psychosis relapse is another possibility using social media data. So this is a study using 53,000 retrospective, so going backwards, Facebook posts from 51 patients who all had a hospitalization and then a subsequent relapse for psychosis. And they found that as patients were nearing a relapse, the types of language they posted on Facebook changed, right? So they were more likely to use swear words. They were more likely to express anger, to mention things associated with death. And they were more likely to be socially withdrawn, and the way they identified themselves changed. The personal pronouns changed. And they were able to predict psychosis relapse with 71% specificity and 38% sensitivity, which is not stellar, right? It's not ready to be, released in mass, at least based on this study. However, I think it's worth considering that right now, I have 0% specificity and sensitivity in predicting psychosis relapse because I don't have access to any of this data. In fact, it would be just a plain guess if I were to say when a patient would relapse again, even assuming that they are taking their medications. Now, the passive types of data, I think, are very interesting, especially for functional state, which is what you were talking about, Denny. And so we often ask people how active they are. Do they ever have periods when they have a lot of energy? Perhaps thinking about mania, or the opposite of that, which would be depression. How much sleep do you usually get? It was a huge clinical question across multiple diseases. Sleep is correlated with multiple disease states. We ask people how social they are. How's the relationship with their friends? And so this idea of, mobility or activity, sociability are two of the three components of functional status, which we usually measure with clinical scales like the short form 36. There's also the FACT-G, or the pain and enjoyment of life. And so these are really excellent at helping us gather subjective symptoms, right, in a standardized fashion. However, there are still those dependencies and those limitations of those data, which I described earlier. And so an example of how these types of digital phenotypes might improve upon clinical scales can be found in the way we evaluate ADHD today. And so say you had a child who was hyperactive in school, and you went to a neurologist or psychiatrist. They would give you the scale to then give to your kid's teacher. And then your kid's teacher would evaluate how often Timmy, or whoever, runs about or climbs excessively in situations in which remaining seated is expected. They do it never, occasionally, often, or very often. And so what would happen is they would score up this clinical scale and then output a final score as a measure of how severe a child's ADHD is, which seems like it's very reasonable. This is still kind of the gold standard in ADHD treatment. But consider if you were having chest pain and you went to a cardiologist for this, right? And they asked you to rate how often you have bad chest pain, 0, 1, 2, or 3. And that's the way they left that evaluation. They didn't have any temporally stamped information about when it occurs, things like that. I think we would probably find another cardiologist. Uh, so back in the 80s, I say back in the 80s, this is before I was born. There was Linda Perino was doing a postdoc at the NIMH, and she and her group had this idea of using an accelerometer, this device that was the size of a fanny pack, recently developed at the NIMH. And they wanted, instead of just gathering clinical scales, they wanted to give these to young boys and see if there are specific periods of the day wherein they were more hyperactive. Like, is this math class? Or, oh, it's noon. Maybe that's lunchtime when they're more active, right? Or maybe this is math class or the beginning of school right here. And so they had trouble settling down, then there's lunchtime and then recess, or, you can create a story for that. But what I think is most engaging about this data is how elegantly it shows the difference between placebo and the drug right here. And so you can see that the hyperactive behavior of these children was essentially normalized with a specific amount of dextroamphetamine, which remains a treatment of choice for ADHD. And so what she was proposing in the study is that accelerometers could have value both in identifying and in treating childhood ADHD. However, it's 2022 now, and we don't really use accelerometers in this way. We still use the Vanderbilt scale. And I think that's a real loss for our ability to gather large scale data and then to titrate medications to the minimally viable dose, which is the way many other medical specialties use it. Here's an op-ed or a expose, I guess it would be, that was from the New York Times a few years back. The New York Times had revealed that a woman's app was recording her location 8,600 times once every 21 minutes and could actually trace where she was, and which absolutely without your consent, it can be very alarming and inappropriate. However, when I look at this data, I'm thinking, wow, look at this really cool curve. Like, you can see a density plot of where this person was, where they often travel throughout the day over time. You can see outliers, like, oh, she went to the airport here. That's not usual behavior based on the density. Maybe she went hiking. And so this level of GPS data, appropriately gathered, respectfully managed and securely analyzed, can be helpful in us identifying patterns in patients' behavior. And the reason why patterns are important is just like any other field of medicine. We use patterns to understand when things are functioning properly. So this is what's called a pressure volume loop. And it's, one of the basic things you learn as a med student about heart function, right? So your left ventricle is filling with blood, and then your valve shuts, and then your heart contracts, and then boom, all of a sudden, your aortic valve opens and all of the blood goes out to your body. And then you can understand where you are in the cycle and also specific disease states based on looking at the pattern and looking at how the pattern changes in certain disease states. And you can see whether you have too much preload, not enough preload. And then based on those patterns, you can identify which treatments might be helpful, right? And so that's where I would envision this type of pattern analysis moving towards being able to predict useful clinical outcomes. So this is a study out of J.P. Arnold's lab at the Harvard School of Public Health, where they were gathering these types of passive data points, trying to predict relapse in schizophrenia. And so they were showing that these types of data, when you can define a pattern and then see a variance from that pattern, outlier from the pattern, you can then begin to predict something that's useful.
Question, Dr. Barron. Accelerometers have been around a while. You'd think that someone would have said, we need to put bands on these kids' wrists, and we need to, obviously with parental consent if they're young children, or with the consent of the patient if they're not. what do you see as being some of the barriers to not using that more commonly in clinical practice or in research?
Great question. And I think one of the big clinical barriers is being able to manage the data and make sense of it, right? And obviously Linda Perino had found a cool way of doing it back in the 80s. And even now, like almost everyone has an accelerometer in their pocket. Every smartphone has an accelerometer. However, can we define a clinically useful signal based on that? Can we import that and present it to clinicians in a useful way that they can make sense of it? And in the same way that blood pressure and heart rate are part of, vitals, which is a billable service, part of a standard clinical visit, can we incentivize that level of data collection by, creating a panel of measures that, if proven to be clinically useful, can then be gathered in a clinical setting? All right. So I
Okay.
think it's really entering the clinical workflow is the problem there. And again, maybe I should phrase that or rephrase that in this. There have been decades of studies showing that blood pressure and heart rate are related to clinical outcomes. And so being able to prove and that certain measures are clinically useful would be a necessary precondition for including those into kind of a vitals for mental health, right? Which is where I think this is going, and that's what I want to describe in the last section. Like, what do we want the data to tell us?
Okay, good.
Okay.
That's good to hear.
And so I'd like to talk now about conversational data, or this video data. So this is when I was a resident, I really wanted to try to develop an instrument guided exam for the mental status exam. And so the idea is that if based on my conversation with the patient, I'm gathering enough information to perform what's called a mental status exam, describing the patient's speech process, mood, thought content, why couldn't I record our conversation? And then in the same way we measure blood pressure, produce quantitative signs to capture the same thing. And so as a resident, I was fortunate to get some funding, and I worked with this wonderful group at IBM, Steve Heisig's group, to analyze data that I had gathered on inpatient unit every day from admission to discharge. And so I have a 3 to 5 minute conversation with patients. And over time, I was able to see myself clinical improvement, which is why they eventually were discharged. And so the goal was to see, can we measure something that correlates with that clinical improvement? And so video data can be thought of as, has face data. It's like what you see. And there are algorithms that can automatically label different features of the face, like the mouth, the nose, the gaze can be automatically quantified, like where someone is looking. And once labeled, you can create motion analyses. You can understand the expressions, label the expressions that people are making, and you can see how fluidly those expressions change over time. And that, again, this is everything our brain is already doing during a clinical interaction, but can we measure those things? In terms of voice, so what you hear and what someone says, you can transcribe the content of the speech and then begin to understand what someone is saying based on how well their ideas flow one to another, types of words they're using, whether the words are more positive or negative, right? So semantic analyses, and then psycholinguistic analyses. And then you can also analyze how someone is saying something. So how their voice sounds. Like, does their voice sound monotonous, which is something we would typically note in our chart. But right now, monotonous is the equivalent of rapid pulse. We can actually quantify the monotony of someone's speech. We can quantify how many breaths they take in between, syllables or phonemes, the smaller part of a syllable. And over time, we can create kind of a panel of measurements, which can be useful in the future of really understanding what we describe as mental status. And so the results of our study were recently published. So this is a preliminary evaluation where our goal was just to see if consumer grade equipment, so off the shelf equipment you can go and buy at Best Buy or off Amazon, could be used to record clinically valuable data. And so what we did here is we were trying to operationalize psychomotor activity. So psychomotor slowing is something that is commonly associated with depression. And we found that, so the diameter of the circle here is related to depressed mood. So the bigger the circle, the more depressed. And then velocity, head velocity, so how quickly they're moving their head around, is along the X. And then along the Y, the gaze velocity, so where their eyes are looking, is along the Y. And so we see psychomotor slowing, which is associated with depression. And as that psychomotor slowing decreases, or rather as they start to move more, overall patients appear less depressed. And so we thought this was pretty cool. Another feature that we quantified was vocal signatures, so how someone's voice sounds. And so here's a patient who came in on admission, and very monotonous speech, very depressed. And then at discharge, this patient's speech is much more varied. So you can see it's kind of a constricted vocal signature here, which then kind of expands at discharge.
Dr. Barron, are you comparing a
Yeah.
person's language against their own typical language patterns? Or are, different people have varied in speech patterns, vocabularies, manners of speaking? They can be native speakers. They may not be good with the language. Level of hesitation. Do you look at it is it adjusted for, per patient? You see that this patient at one time spoke in a more, fluid, their eye gaze was directed, and then they went and started speaking very slowly or very haltingly. Their eye gaze was frequently averted or unfocused. Is that kind of how you look at that on a patient by patient basis? Because these patients are very different, which in psychiatry has got to be like one of the preeminent themes. Everyone is very different. It's hard to bundle them into a group. Is that how that works?
So that's true to some extent, right? So if every patient was completely unique, then clinical training would have no value, right? So if everyone was a sample of one, then there would be no point in, even referring to something as depression, because I will show later on that there are many different types of depression, but there's something generally communicated by the idea of depression. And across individuals, there are individual differences which are significant and I think should be addressed. However, the idea that we're presenting here in this plot is each individual is their own color. And so we can see how they change over time, just using a standardized measure. And you can see kind of where they move throughout their course of treatment. And behind this, which I didn't go into, is the density plot of 150 people, where we're showing the same measures across a much larger sample. And so there is some commonality across patients in the way that we use our head motion and gaze, which is simply focused by being in conversation with someone, right? And so speaking with someone, you're less likely to turn around in your chair and not face the camera, which is something we would have picked up on, which also would be interesting data. And this patient right here, this is a single individual's change in vocal signature, right? And so that's what we thought was most relevant there, not just comparing one person's voice to all other voices, but how does that single individual change over time, which is kind of what you'd be listening for as a clinician in that evaluation.
Do the numbers correspond with their visits or their encounters? Is that what the numbers are?
Right.
First encounter, second encounter, third encounter, that kind of thing?
That's right. Okay. Every day. Yeah, I didn't dig into it. Didn't dig into it. So you're absolutely right. So day 1, day 2, day 3, day 4. And so you can see them moving over time. And again, this is a preliminary study. We were just trying to flex our camcorders, essentially what it amounted to in the algorithms. I'm hoping to gather this data in a much larger sample. And, that's currently underway here. Hopefully to define better measures that can then be useful over time. Another data point that we thought was interesting was the level of conversational effort that a clinician had to put into getting information out of the patient, right? So this could be like, you can imagine this like a patient who might be manic. All you would have to do is ask them like, hey, how's it going? And they would just be off to the races and you wouldn't have to
They
say
take
anything
off,
again.
right?
They would take off. Whereas a patient who's very depressed, you might have to really kind of pull information out of them. So the number of words you might have to expend in order to get information would increase. And so this is a simple plot, similar thing. The color is per patient, day 1, day 2, 3, 4, 5, 6. And the number of words the clinician had to expend versus the number of words the patient produced as a result of that. And the overall trend, which was not statistically significant, is the larger circles, or less speech overall, which they just weren't that interested in engaging. And then the blue patient here is one of our patients with mania, and this patient didn't require much interaction at all. And in fact, the same patient, still in blue here, had a delusion that they were a world-class consultant. And so for the first few days, this is all this patient wanted to talk about, which is something a semantic similarity analysis picked up on. Right. And so the patient comes in and has this delusion that they're doing business and highly successful, which is eventually what brought them into the emergency room. And then with Depakote, the frequency of words related to consulting essentially normalized here. And so we can see here it becomes very similar to what other patients are describing in the course of their conversation. And so again, this isn't like a slam dunk analysis, but our conclusion was it seems feasible to begin to measure visible and audible aspects of the mental status exam specifically from unstructured conversations. And so we're going forward with that. Another way of representing the data would be with a speech graph, which is, I think, a really cool intuitive approach to tracing someone's thought process, right? And so you can imagine you could trace that I walked to a place and found grandma, and then I hugged grandma strongly, and then I woke up in my dream, right? So this is describing a dream.
Right.
Whereas a patient of schizophrenia might have impoverished speech, which isn't directly connected. And you can actually see the impoverished speech here in relation to what a healthy control might describe. And then at the same time, you might be able to appreciate this as a manic looking figure where they're just kind of all over the place. And so again, these are different things that we would typically document in our clinical note. However, there aren't really quantitative ways of measuring that now. And then recording these types of data allows us to begin to predict similar useful endpoints, such as psychosis. This is a study out of Cheryl Corcoran's lab. She's now at Mount Sinai, wherein she performed a latent semantic analysis of unstructured speech. And she was able to predict with very high accuracy, and this is a very good looking area under the curve here, the later emergence of psychosis up to 2 years later. And then she showed that in the dotted line that this generalizes to an independently collected data set pretty well, pretty darn well. And so promising again, having the data, being able to gather the data and then perform statistical analyses on it allows us to do useful things that no clinician could do. I couldn't imagine a clinician predicting based on a few minutes of conversation the likelihood that a patient will become psychotic in the future with the high level of accuracy. That'd be extremely complicated, but someone might be able to.
But you're showing on that previous page that kind of graphing and plotting that kind of manic, possibly incoherent, possibly overwrought, but definitely rapid elucidation of their waking and their dreaming, but especially their dreaming, that based on that one or a few observations, that you're able to, or the scientist who was referenced in the subsequent page was able to predict with some degree of reliability or some degree of accuracy that was a patient who was more likely to be psychotic at some time down the road than a patient who wasn't. Is that correct?
Right. So this is a like at the present time study, right? So
Right.
cross-sectional. And then this here is a predictive analysis. Different patient populations, but yes, similar idea, right? So we can learn useful things based on analyses of data, of the same data that our brains would be looking at. However, some of the signals are too subtle for our brains to pick up on, right? And so, whereas I would suspect that even a layperson would be able to appreciate impoverished speech here and then manic speech here relative to a healthy control. I'm not sure whether any clinician could predict, the subsequent development of psychosis from these were clinically high risk patients already, but being able to predict whether someone will actually become psychotic a couple of years in advance is quite a feat.
Really?
Yeah, and of course, being able to, Cheryl Corcoran's lab is following this up and collecting more data to really refine this tool to see if it could be clinically viable tool. But it's definitely, I felt that it was promising, and I think it's pretty exciting.
The dimensions that you have represented on the chart on the left, someone with minimum semantic coherence and
Right.
long phrases, maybe, I don't know, but
Sure.
maybe very short phrases could be indicative of what are determiners in this particular context, the third axis. What are determiners?
So a determiner is actually, I wanted to say it was a pronoun. I don't remember. I should figure that out. Yeah, I'll get back to you on that.
Okay.
Yeah.
I mean,
Yeah.
those could be factors like poverty or factors like
Oh no, yeah, it's
disability,
not
or
it's
not
a
a determinant.
linguistic term. No, yeah, not like
Okay,
a social determinant of health. No, yeah,
got
the
it. Okay.
determiner. I can't remember if I described this in my book. I don't remember, and I don't want to guess because I don't want to be on the record saying something inaccurate. I'm sure they describe it really well. The semantic coherence would be one idea to another, and then the phrase length would just be like the chunks of ideas. Like you consider that like a sentence or a paragraph length.
Right.
And um, I want to say I've written here the possessive pronouns. I wonder if that might be a type of determiner, but I honestly, I don't remember exactly what a determiner is.
Like
Um,
referring to oneself in the third person, or
exactly,
referring to oneself in the first person.
exactly.
Okay.
And so stress tests, I described that in the book, but just for one of time, I wasn't thinking we would have enough time to go through all of that here. So I'd encourage you to look it up if you're interested. But really what I think is fun and what I'm working a lot on in my lab now is what are we going to do with all these data? Like how can we make sense of them in a useful way? Oh, and there's that darn chromosome again. Okay, so again, tons of data, especially across the lifespan, right? And most of these data are not relevant, right? So if someone comes in and says they're hot and shaky and they're warm to the touch and they have a fever, it really doesn't matter what they felt like when they were, 1 years old or 15 years old. I mean, this is the snapshot that's relevant. And the reason why, again, is you have a clinical problem to solve and you need to gather data that serves, to minimize the uncertainty of how to act. And so here is a very standard list of labs for someone who comes in. Maybe they report, nuchal rigidity or stiff neck and fever. And so you get full workup, right? So this would be a very standard full workup where you get chemistry labs from the blood, you get white blood cell count, red blood cell count. You get a CSF because you might be worried about a CNS and a central nervous system infection. You get vitals, you get an EKG. Maybe if you're convinced later on that they have cardiac disease and maybe this is related to chest pain, so maybe you get a stress test on some level. Who knows? Depending on what this data would guide you. The point is there's a lot of data in every patient's chart. And then on any given clinical problem, you need to be able to make sense of it, right? So you need to be able to figure out how to combine these data into a useful way. So the question boils down to, like, what are you actually going to do with it? And so a lot of work is being focused on diagnosing. And I think there are a few problems. Oh man, I didn't realize I had this in there. There are a few problems with predicting schizophrenia. In fact, I'm getting ahead of myself here. How many people do we have? We have 8 people. I'm just going to skip that part. Let's not worry about it.
Okay.
Yeah, so we can predict things like diagnosis. However, I crunched the numbers for diagnosis of major depressive episode. And it turns out that there are 488,000 combinations of symptoms that can lead to a diagnosis of a major depressive episode. Right. And so these are the diagnostic criteria. And it's kind of like a choose your own symptom pattern. If you have depressed mood, either by their own subjective report or by an observable clinical sign, then that meets criteria 1A. A3 can be met with weight loss or weight gain. So that's A3. Insomnia, hypersomnia. And so what I'm suggesting here is that there are many different combinations of symptoms that can all meet the same criteria for major depressive episode. And if we look carefully, a lot of these symptoms are opposites, right? So insomnia versus hypersomnia, weight loss versus weight gain, and being able to predict a useful biotype, which can then be treated, may not be the most useful way of going about a large-scale machine learning analysis. Or, if we're going to gather a bunch of data, predicting who has depression and who doesn't may not be the right way to figure out what treatment. And schizophrenia is even more complicated. So there are actually 7.7 trillion different ways to diagnose schizophrenia based on the diagnostic criteria, different combinations of symptoms that would lead to a diagnosis of schizophrenia. And so the likelihood of you being able to create a generalizable algorithm that, based on large-scale data, can predict the presence of schizophrenia it's a hard problem and be pretty low. Whether someone's going to have a relapse of psychosis, that's a more clear endpoint, right? And that's something that is a more tractable problem. So a lot of these studies coming out trying to predict schizophrenia or autism or depression, those are very difficult problems to solve and may not be that clinically useful, right? So here's the standard approach to chest pain, right? So this is the way every medical student's trained to think about chest pain. And so if you come in with chest pain, you get the vitals. Are they stable or not stable? Do you get an EKG? Does it suggest acute coronary stenosis? Yes or no? You get a chest x-ray, yes or no? And so what this is they've done large-scale studies. They've done t-tests. And with all of the data that they've collected, they're looking for very clear endpoints, which is how to treat the patient way down here. But the idea here is this is not a traditional machine learning approach. This is just a series of t-tests that have led someone down a series of thinking in order to figure out what to do to help a patient, right? And so instead of diagnosis, what they're doing is figuring out how to treat someone. Another strategy for gathering large-scale data is called the Bayesian inference. And so Bayesian methods are a little bit more complex computationally, and they require a ton more data. So whereas each of these branches was probably one study with a t-test involved, like what a Bayesian analysis does is it gathers lots of data together, and you can understand with all of the data together what the likelihood is of a given outcome. Like, should I give this patient a treatment for a heart attack, or should I, initiate the cath lab or something like that? And so each of these individual data points are weighted within the context of the entire data set. And this is where a lot of research is heading now, because it's more akin to what a clinician's brain does. So instead of kind of a stepwise fashion like that, we evaluate a patient, talk to a patient, and then we understand across all of these data what actually is going on. And then we come up with a clinical plan, right? It's not a plan A, plan B, plan C sort of fashion.
It strikes me that in this example, what you are doing is you're seeing a range of results, findings, expressions, quantitative analyses of a patient's condition that would be even more revealing if they weren't attributable to other health factors that the patient might have, right? When you weight these considerations as a clinician, you might look at the fact that this person being obese versus not being obese may, in fact, if not create, at least weight some of the other findings about that patient, labs, heart, cardiographic or cardiological analyses. Is that part of the, I'm sure that would be what happens in the clinician's mind, but as far as creating a model of that, are you able to model for symptoms that may be as much attributable to other factors that are not psychological, or do you look at the presence of those symptoms among a large group of symptoms and say, this is more than being morbidly obese, this is pointing to something else? How do you pull out data that might be attributable to something unpsychological, or at least weight it accordingly?
Sure, yeah. So just return to the chest pain example, right? So chest pain or palpitations are very common in a panic attack, right? Or generalized anxiety disorder. People can have this tension in their chest. Even in some cases of psychosis, that can manifest as anxiety. I mean, it's pretty scary, hearing or seeing things that aren't there, or, having paranoid delusions that can be very anxiety provoking. And so what you would do is you would gather all of the data, right? Obviously, as a clinician, what you're worried about in an emergency room is if this person's having pain in their chest, you go through and you think, okay, what are the things that I can do to save this person's life if indeed they're having a heart attack? And so you have to exclude those things. However, at some point, once you've gathered enough data, the pattern is such that, you can exclude the most threatening causes of chest pain, and then you end up with maybe this person's having a panic attack.
Right.
And so you can kind of whittle it down after a while, which is, again, just a question of how much clinical data have you gathered to reduce your uncertainty. So that's
one of our audience members asked, are you creating a Bayesian belief network or something else? I don't know what a Bayesian belief network is, so I'm really reading the question from the prompt.
Sure. So the idea, so yes, this would be kind of a Bayesian belief network. So we could frame the question of how much do I believe that this patient's chest pain is caused by myocardial infarction, like a heart attack, right? And so you would have a number outputting that conclusion. And you could also say, what is my belief that, or that this patient's chest pain is related to panic attack or anxiety? And so if you gather data, say you get an EKG, which shows no evidence of, any changes in the electrical activity of their heart, right? Maybe they have a fast heart rate, but the electricity seems to be flowing normally through the heart's muscle. If you gather a blood measure of that troponin, that SOS signal from the heart's muscles could suggest a heart attack, and the troponin level is normal, then your Bayesian belief that they're having a heart attack would be very low, right? It wouldn't be zero because, it's possible that they might be, right? Maybe their heart, maybe they just don't have enough troponin, or the electrical activity through the heart's muscle looks normal, or, whatever reason you come up with, but it would be low. And at the same time as the likelihood or your belief that the heart attack is not present goes lower, then your belief that someone's anxiety or panic is related to their chest pain would increase. Right. And so this would be a way of modeling those beliefs, or the likelihoods is another way to think about it.
Okay. Thank you.
Question, which is very hard to do. I don't mean to come off as saying this is a really straightforward thing. I mean, you have to gather all of these data points in a large sample in a standardized way. And you have to have the foresight to do that, right? Because gathering data in a standardized way throughout a large sample is a very operationally complex thing to do. And then you have to have the ability to make sense of all those data by analyzing them, which is computationally very complicated. And so this is a much more complex strategy than the t-test method. However, overall, it is much more along the lines of what we think in terms of clinicians, like in terms of a differential diagnosis. And also, I think much more powerful, because whereas this learning tree, like this series of t-tests, you can adjust each individual point with more data, right? Say you were to go from 100 to 1,000 data points, you could adjust each individual t-test, and maybe this would reorganize. But the Bayesian network, or the Bayesian models here, the entire model could learn from more data. And so that's one of the reasons I think it's really, really quite compelling. And again, this is kind of the way that we think as clinicians, right? So I had mentioned at the beginning that clinical training is kind of a Bayesian learning algorithm, where we're gathering this large sample of data and we're understanding the common threads across different patients. And we're trying to understand what's going on and associate specific observations with treatment. To put it into a Bayesian model, you would have to be able to quantify all of the data you think are relevant. And I think one of the cool things is, instead of diagnosis, maybe what we'll begin looking for are things like decreased mobility, like hypoactimetry, which would be the accelerometer data, like less mobility, not moving around as much. And then maybe to your point, instead of asking someone for their pain score, we would just assess their functional status as, how mobile are they? Do they look like they're doing better based on their video data? Are they interacting with their friends and family more as a result of, whatever treatment? And also being able to operationalize and really measure a decision process, being able to pull these data together and understand how they interact to produce an outcome, allows us to then refine that model itself and to improve the way we're assessing it and treating patients.
These become, in essence, psychological equivalents of the physical vital signs or measures that you showed in the previous slide.
Yeah.
82% showed hypoactimetry, 18% showed, hyperactimetry. You go through expressivity, you have these different markers that you are then able to, if you have enough subjects, start doing distributions for each one of them. And then you look at all of those in total, you can then start to run your model, if I understand you correctly.
Right. So the distribution you're talking about is key, right? You have to create what's called a normative distribution, right? And so that's, to bring it back to blood pressure at the beginning, one of the things that people weren't able to appreciate at the time was that FDR's blood pressure of 180 over 80, or I think 180 over 90, that was really quite high.
That was very high, yeah.
That was very high. And we would absolutely treat that probably in an outpatient setting, but it would be pretty aggressive treatment for an outpatient setting. And then his blood pressure of 220 over 110, or, the 220 measure is really high. That would be a visit to the emergency room. That might even get you into the ICU nowadays. And the reason why our treatments are different is because we've measured blood pressure in thousands and thousands of people over long periods of time. And so we appreciate what that indicates in terms of outcome, right?
And what normal is increasingly becoming, what really constitutes normal as in normative. If it's 200 over 150, we're all, we're all going to die of heart attacks before we're diagnosed. But if it's 100 over 30, we're all in big trouble, right? So we have to sort of first establish what constitutes the normative baseline, if I understand what you're saying, before you can do any kind of distribution analysis, over, under. super over, super under, et cetera.
Absolutely right. And the idea that I'd mentioned that in the late 90s, what was hypertension, 130 over 80, is now not, maybe I say this, the definition of hypertension changed. So it went from 130 over 80 to 120 over 80. And that wasn't too, I remember when that change happened, people were like, the cardiologists just want more business. This study was funded by the companies who make antihypertensives. And you could view it that way, through a certain worldview. I guess the other conclusion would be that they did large longitudinal analyses and they observed that the likelihood of heart disease was also present in 125 over 80. And so clearly that wasn't a normal or healthy blood pressure long-term. And so that's why they changed that definition. It was data driven. And that level of analysis right now isn't really possible in psychiatry because we haven't gathered large scale amounts of data in the same way. People are beginning to do it. And there are many large groups who are currently collecting data. And so the concepts which I've described here are, I think, going to be progressively more relevant. The more data we gather and the more we learn about, these sorts of normative distributions and what that means in terms of future outcomes. And that's about it. So I've described the clinical problem, gave a historical context for cardiology's kind of path through data analysis over decades. I described a series of clinical instruments or tools that are providing evidence for how they might be analyzed to predict useful outcomes. And then I've tried to emphasize and describe how I think combining these data to help us better understand clinical outcomes and clinical decision will be helpful. And I'm very grateful for the support and collaboration of a very large and helpful mentoring group. And also for the funding from the NIMH when I was in residency, and then now from NARSAD grant, and hopefully soon from the NIH for my study for my pain center. So I'm happy to take any other questions if you have them, or
yeah, we do have a couple. We have a couple of questions that have come across. One is we're moving, at least from our vantage point, from the Health Data Consortium's vantage point, we're moving to a health data economy where more and more of what constitutes a patient's complete medical record, not only the one that is crafted in their clinical setting, but may also include digital devices, their nutritional habits, their exercise habits, et cetera, that more and more of that data is going to be on the patient's smartphone or their smart device. And the question I have is, assuming we have a consent framework in place where people say, yes, I would be interested in having my social media accounts evaluated, my Google searches assessed, the conversations, a regular tracking tool that allows me to answer a few prompts every day about how I feel or whatever, I'm willing to let you do that. How far do you think we are from having, that kind of data converted into what you're working on, which is usable clinical insights that clinicians can act on, even when they're not seeing the patient? They have signals coming in. A patient-centered world takes on a particularly, intriguing kind of intriguing characteristics when we're talking about psychiatry. And while people can do their blood pressure at home, they can do a number of other things at home. How close do you think we are at being able to have, the smartphone being the repository of enough information for you and others in the field to begin to make informed assessments about the patients who you're evaluating this way? Are we 10 years, 5 years?
I think it boils down to what you hope to accomplish with the data, right? Like, I think if you think of blood pressure, cardiologists do a lot of stuff that aren't related to blood pressure, right? Blood pressure is a very useful measurement, essentially as a screening device for other diseases. But I would imagine that, excuse me, the question would be, what are the data going to be useful for? And who's going to pay for that data collection and analysis, right? So whereas blood pressure is a pretty straightforward measurement, you can, have a blood pressure cuff. And then with that simple measure, you can, diagnose quote unquote hypertension or normotension. It's be much more complicated for psychiatry. So certain measures like sleep, the duration of sleep, or, sociability, like how interactive someone is with their social network. We can measure those now, right? Pretty straightforward. I mean, you can measure your step count. You might even, if you have a smartphone, that you've activated this function, it might even tell you when you've closed a circle, on your exercise count.
Yeah.
But what do you do with that though? Right. So the ability to collect and store data is already there. And in fact, to your point, there's probably a lot of this data already on your smartphone. But how do you make sense of that in a way that's clinically useful? And so I don't know. I don't know when that's going to happen. There are a lot of really smart people trying to figure it out. I'm one of the lesser of the smart people trying to figure it out. And the biggest complexities that I've run into are, how can we organize these data in such a way that you can begin to make sense of them on a group level and then on an individual level? And then how do I pay for gathering, storing, and analyzing these data? And those are huge obstacles, right? If you want to implement it within a healthcare system, somebody's going to pay for it. And it's not clear what the data are going to do in terms of clinical decision. And so I think that's why a lot of not a lot of this has been formalized within the clinical ecosystem yet.
We have another question, which is, how do you get consensus on what data is and is not useful from the standpoint of treatment? Obviously, this is something that isn't always clear. Going back to the pain example, is it as simple as subjective versus objective level of expertise of the observer? How do you get consensus on what is useful from the standpoint of treatment?
That is a great question. And I did not have a slide on this, and I wish I had. And so one of the things that some studies have tried to predict is treatment outcome, right? And I think it's worth observing that, two things in psychiatry. One, if you are diagnosed with, say, schizophrenia or major depressive episode, the goal really isn't to undiagnose you with that, right? So you're not trying to cure schizophrenia or depression in the same way you're trying to cure like pneumonia, right? At some future point, if you have pneumonia, the motivation of treatment is that you will one day no longer have pneumonia. Right?
Right.
These are different types of diseases. So then if you're not going to do away with or some way cancel out the schizophrenia or depression, then do you look for a symptom burden decrease? So is the depression less severe? Does someone's hallucinations, do they decrease in frequency or severity over time? And even then, across people, it's not clear that those are good measures. And the reason is, you can imagine two patients, each who report severe and distressing hallucinations for 6 out of 7 days a week. You give them both the same medication at the same dose, and both of their hallucinations and the severity decreased only 1 day at a very tolerable level. However, their individual goals are such that the first patient is no longer able to attend university because they can't focus, because antipsychotic medications are somewhat sedating. Not somewhat, they are sedating in many patients and might cause foggy, cognition. Whereas the other patient who's not a university student has no problem at all. And so even though the symptom severity has decreased the same way, the overall hopes and goals of the patient are different. And also their response to the medication is different. And so it's not clear how to develop a group-wise consensus, in that sort of trial. And so I suspect that what would happen in the future is that, we'd be able to gather data about patients' expectations, their overall level of function, what is important for them. And we'd be able to train algorithms or, these Bayesian belief networks, as someone called them, to help us identify which treatments might be most effective. And the reason I think that is that it's essentially what's happening right now already in a one-on-one patient interaction, right? So before any clinician prescribes a treatment, they'll talk to the patient, explain the risks and benefits of the treatment, what potential side effects may be present, and then they'll talk with the patient to see if it's, worth a shot for them. And being able to operationalize that on a large scale, that individualized tailored treatment, is where I'd envision it going in the future.
One of the things that stood out in the Churchill physician's assessment of Roosevelt's condition was that the amount of data, as we would think of it, that he had was quite limited. I mean, he didn't take his blood pressure. He didn't, do any kind of physical examination. He just looked at FDR and said, "This guy's hurting. He's not going to make it." And in some ways, what you're characterizing in psychiatry is how do we deconstruct what is incredibly powerful informed knowledge, clinical inference, intuition that says this guy looks bad, he's not going to make it. That came out of the ether. That came out of relatively few quote unquote data points, but it did.
Right.
Behind that was a wealth of knowledge, probably as best represented by those Bayesian normative networks that you described, where he is going through in his mind. This is his bloodshot eyes, his complexion, his
very
agitation,
pale,
he was able to sort of immediately synthesize a range of normative, factors and say, not good on speech, not good, less than good on complexion or pallor, fingertips look, betraying, lack of circulatory problems, and a whole host of things. When you meet with your colleagues and you talk about what they understand in the therapeutic encounter, as Churchill's doctor did of FDR, how do you deconstruct that and create, these Bayesian networks? I mean, what is it that makes it good? It's kind of what makes a good shrink, right? It's kind of, how do they do that? How do they put all that together and say, I know that this patient is not experiencing just panic attacks, but is near borderline psychotic or borderline schizophrenic? How does that happen? How do you deconstruct that encounter?
It's extremely difficult. So I remember as a resident, I came across this essay called "The Case of Double Supervision," written by Eric Nestler, who is now, I think he's the dean of research at Mount Sinai. He actually, I didn't realize it at the time, but he had graduated from the same residency program that I had at Yale in the earlier version of the neuroscience research training program. And not long after he graduated from residency, he wrote this, it's like a series of case studies. It was more of a vignette style paper. And it caused a lot of controversy in the department because he was a new faculty member. And what he was describing in this paper was a single patient that he evaluated, and he presented his evaluation. So all of the subjective symptoms and the qualitative observable signs that he had gathered, all of his data, he presented it to two different attendings, two fully certified clinicians or psychiatrists, and then later presented it to a group of psychiatrists. And in this paper, he describes how orthogonal their conclusions were, treatment decisions were, based on the same data that he presented. And in fact, one clinician had criticized him for starting this patient on an antidepressant, saying that his decision to start the patient on an antidepressant was more of a reflection of his own frustration and feelings of essentially impotence in treating a complex condition, right? It's definitely worth a read. It's a fascinating read. And then in the larger group, there were clinicians who thought that, the psychopharmacology wasn't relevant, and some disagreed. There were a wide range of opinions, is what it boiled down to. And so this is a well-known problem in psychiatry. And there are many different types of tools which have tried to decrease the level of variability clinician to clinician. Like that was one of the primary goals of the DSM, which is the diagnostic manual for psychiatric illness. But even then, that still hasn't decreased variability substantially. I mean, it has decreased it relative to no DSM, but over time, there's still significant variability even in diagnosis of the same symptoms. And so, Lord Moran, he had a great learning algorithm, right? And we might describe that as intelligence, right? So the ability to learn from one's environment, synthesize data, to, produce decisions which we believe are quote unquote intelligent, that's very variable across people. And it can be variable not only with the same data, but also with biases specific to a clinician or to a person. And so the reason why I think that operationalizing and really using these statistical methods instead of just training, within an individual's brain, is that you can demonstrate empirically which data points are most salient. And then if you include an outcome of interest, you can demonstrate empirically which treatments are most helpful for a patient with a specific symptom pattern. And so, yes, there's a ton of variability, and I hope these tools will be helpful.
Well, that's interesting about the supervisory model in psychiatry, which is somewhat unique. That right. There is, you need to sort of run by your assessments with a supervising psychiatrist who is supposed to ground you or ask thought-provoking questions, Socratic dialogue, help you, inform your decision. Only in this case, you go out with a well-informed clinical judgment and you have everybody telling you, you're wrong, which right. is not exactly the way supervision is supposed to work, I suppose. We have another question that just came across the transom, which is, how do you deal with extreme outliers? There are folks who are several standard deviations away from the norm. As we move to more and more evidence-based medicine, for folks who aren't in or near the mean, it seems to get harder and harder when people are outliers, sort of beyond 2 standard deviations from the mean. How do you deal with these extreme outliers? How do you look at them differently so that they are not regarded merely as outliers until at least certain questions have been answered or a certain assessment has been rendered as to why are they sitting way out there at the end of the curve and not in the, in the general population?
I think the way I would approach that is really trying to formalize what that means to be an outlier, right? Like in what dimension of the data? Like if we're looking at this, are we talking about an outlier in terms of blood pressure or glucose or, speech coherence or determiners, whatever that means?
Yeah, right.
Like how can we understand and quantify what that means in terms of many different points of data, right? So right now, if I see a patient, like let's just consider mania. Like you can imagine mania exists along a spectrum, right? Where someone might be hypomanic, which is a word that we've created to describe kind of, I guess, the left side of the spectrum. If it goes all the way from
right.
manic on the right, hypomania would be just a little to the right of normal. And then mania would be even farther to the right. Then maybe the word we might use would be floridly manic or extremely manic or something like that. But that's not really that helpful in terms of really pinning down why that person is manic. And so really measuring like we showed in that preliminary study, how is facial expression moving? How is speech progressing? Like, what sort of ideas is that patient focused on? Can we really dig in and understand the actual clinical data that led us to that intuition that they're highly manic or floridly manic? And I think that's the way that I would approach outliers.
I was just going to say too, in the Bayesian diagram you have here, this network, the impact of one of those domains or one of those measures being a person being way out on the outlier, obesity, I can't read that quite, T3, 1.15% of the patients were obese level 3. If that stood out for an individual patient, you have a lot of other domains here that might either support a non-psychiatric diagnosis or inform a psychiatric diagnosis. It's not that observation in isolation. Someone with a very high body mass index, extremely high, that's part of the solution, but it's only a very small piece, and it has to be looked at in the context of a whole system of other measures where that patient may not be an outlier, where they may be. But if they're an outlier on a number of these, I would suppose we would be looking at any host of possible outcomes or symptoms or underlying diseases.
Yeah, I mean, I think guiding treatment and guiding clinical action is what I think the most compelling motivation is for me. And even this figure here, even though it's meant to, the focus of the paper was, how do you evaluate and work up essentially heart disease, which is what the paper was about. These measures would be important in psychiatry in the case of schizophrenia, because some antipsychotics can worsen obesity or create metabolic syndromes, and so these same data points would be related to a psychiatric decision model, especially BMI. I mean, if you have a patient who's, obese type 3, then you would choose very carefully which antipsychotics you would want them to be on.
Right. Well, I want to thank you, Dr. Barron, for a great and fascinating presentation. You picked a universe of data that is, you must feel like you're chipping away at times, like at the top of the iceberg, and you may get down to sea level, but below you is, 90% more of what you need to find out. But this is fascinating work, and the use of data to begin to understand what has been historically the province of people who are good at interpretation, people who are very good at, Winston Churchill's doctor's level of insight and expertise, making that more consistent with the way we treat non-psychiatric medical conditions, being able to inform treatment decisions, to inform the course of care with more science is it's a tremendously exciting area of work that you've picked. And I think what you've shared with us today is very insightful. It's exciting to see. For me personally, to see this level of analysis applied to something that has been so highly interpretive before. And I want to thank you for spending your time with us today. I also want to thank our audience. Thank you for joining us. Thank you for your questions. And I appreciate your sending them to me. We could have put them in the chat and we would have all been able to see them, but I appreciate your sending them to me to ask Dr. Barron directly. And I thought your questions were terrific. So on behalf of MHDC, I want to thank you all for joining us. Again, Dr. Barron, I want to thank you. I greatly appreciate your time today and your sharing with us what you've uncovered. And I have one thing in here that says, yes, there will be a recording of today's presentation available. And if we can use your presentation, Dr. Barron, or a version that you approve to make available to folks afterwards, that would be great. But we will have the recording of this webinar on our website. You can access it at that time, and we'll get a copy of the presentation from Dr. Barron for folks to use also. With that, again, I want to wish everyone a good day, and thank you all for joining us, and we're adjourned.
Yeah, have a good one. Bye, y'all.
Everybody, bye-bye.